Good morning. On behalf of the Board of Directors of the Raymond A. Wood Foundation, I welcome you to the Pituitary Brain Tumor Virtual Conference. My name is Amy Wood, and I'm the Executive Director and mom to Alex, a 10-year-old craniopharyngioma survivor. All of us here have been touched by a brain tumor, whether you are a survivor, parent, spouse, other family member, or medical provider. We are all on this journey to finding solutions to the challenges we face every day, whether still battling the tumor or in its aftermath. I once spoke with a parent of an adult survivor who was diagnosed many years ago as a child. She told me how alone she felt with no connection to anyone who shared this experience as a caregiver. This was before the internet and social media. And now we are able to unite as a global community, and we can share our experiences with each other. Although we can't meet in person today, this virtual platform lifts the barriers of geography and brings us all together, all sharing the same goal, to find out more about how we can improve life in this brain tumor journey. Today, we look forward to hearing from Dr. Shana McCormack from CHOP on the latest findings in pituitary tumors in clinical trials. Dr. Christian Roth, a leading hypothalamic obesity researcher, Janet Dietrich on self-care for caregivers, and Dr. James Bay on mind-body resources for health and healing. Today's sessions are concluded by virtual family networking. I hope you can join us so we can get to know each other. If you are joining us again tomorrow, we will be in breakout sessions covering topics including fertility, nutrition, navigating school IEPs and 504 plans, transitioning from pediatric to adult care, and more. This day, Sunday, is concluded by Q&A with Drs. Alter and McCormack from CHOP. And while it's true that technology allows us to come together today, it also has its challenges. That said, you should have received an email with links to the conference schedule and Zoom access for the days you're attending. If you need technical assistance during the conference or have general conference questions, please visit the chat feature on the website, pituitarybraintumorconference.com, and we will do our best to help you troubleshoot. A special thank you today to Dr. Alter and Dr. McCormack of the Neuroendocrine Center at the Children's Hospital of Philadelphia for their dedication to making this event possible, and to Catherine Chang, a fellow Cranio mom and planning committee member. Thank you to all of the presenters that took time out of their weekend to share their expertise with us. And thank you to our gold sponsor, Saniona, and our silver sponsor, Consonance Therapeutics. And lastly, thanks to all of you in our brain tumor community who are attending from all parts of the world. I firmly believe the more we know, the better advocates we will be. Without further ado, I turn it over to Dr. Craig Alter, Director of the CHOP Neuroendocrine Center. Craig?
Yeah, thank you. Hello, everyone. This is very exciting for us too. And I have a little secret is you're hoping to learn a lot from us, but we also learn a lot from you. When you ask questions, it just helps us to be better clinicians, better researchers. We've been meeting almost weekly, sometime every couple of weeks with Amy and the foundation and trying to plan this program. We had a nice live event last year. Obviously, it's not going to be live this time, but in the future, we hope one day to meet up again, and I'm sure we will, maybe even a hybrid format. We have over 130 families that have signed on for this program from all over the place. Malaysia, we got Australia, we got Philadelphia, and need I say more? We realize that people are on different time schedules, and so sometimes when we say noon, it might be only 9 a.m. for you, but we're all here together, kind of live. I would tell you that this program is a really good one that has room for all different kinds of families. Some of you have children with craniopharyngioma, probably the most common family here. But we also have children who have astrocytoma, which is another tumor in the pituitary region. We have some with hypothalamic hamartoma, some with a germ cell tumor called a germinoma, and some with even a different condition. We have some families where their child has just been diagnosed with this neuroendocrine issue, pituitary region issue. And we have some families that have been dealing with this for a long time, which means some of the questions that are going to be posed might be, well, my child for the last 10 years has blah, blah, blah. And some families will be, since diagnosis 2 months ago, we've noticed the following. Can anyone else comment? The teaching may come from fellow families or may come from us. Right? We're going to provide you information on research and also on basics about the pituitary function. We try to make the breakout sessions sort of hit different targets. Like, for example, tomorrow, when we have a breakout session on what's within the pituitary, kind of the basics, versus what if you've been dealing with this for a while and now transitioning to an adult provider, or what if you've been doing this for a little while, but it's more about how do I integrate this with our school? So the program is very purposeful. We've created, I think, something you really like, and thank you for joining us. And now I think I'll pass it on to Dr. Shana McCormack, who's also co-director of the Neuroendocrine or Pituitary Center at the Children's Hospital of Philadelphia, which is part of the University.
All right, good morning and welcome everyone. I'm going to share my screen with you so we can get started. Here we are. All right, that should have worked. Please let me know if not. So welcome everyone. It's morning here in Philadelphia, so I'll say good morning, but also good afternoon or good evening to our guests from all over the world. I really appreciate the opportunity to present to you today. My talk is entitled 2020 Year in Review. A lot could fall under that heading, but I'm going to confine my comments to neuroendocrine research in individuals with pediatric hypothalamic and pituitary tumors. Let me see, advancing this, perfect. Here are my disclosures, but none are relevant for today's talk. This is a really important slide, lots of folks to thank. In the interest of time, I won't spend too long, although I could. First and foremost, Amy Wood and the Raymond A. Wood Foundation have been amazing in hosting us today. The Chang family has been incredibly supportive in initiating this conference and sustaining it. My fellow clinicians at the Neuroendocrine Center, Craig, Chris, Vanita, and Goli, our nurse, Amanda, administrator, Sharon, collaborators from multiple disciplines. Our meeting presenters have been very helpful. Many of you may have met or interacted with my research team. I thank them also. Most important, of course, the patients we take care of in clinic or learn from in our research studies and their families, as well as all of you for coming. As Craig mentioned, we learned so much in the course of getting the terrific questions that you have. An outline for today's talk. I'm going to focus on neuroendocrine studies for obvious reasons. That's my area of expertise. It would be impossible for this talk to be comprehensive, so it's not. A lot of interesting studies ended up on the cutting room floor, but if you have an interest, please feel free to reach out to find out more. Usually I would include a lot about hypothalamic obesity because that's a particular area of mine, but we are so lucky to have my colleague and friend, Dr. Christian Roth, who will be presenting to you on this topic shortly, and it's going to be a really terrific talk. I encourage you to come back for that. Finally, I accumulate these studies every year. If you have any you find that are of interest, please, of course, share them with me. The first topic to address is medical therapy for craniopharyngioma or other brain tumors. This group well knows that in particular for craniopharyngioma, typical treatment includes surgery or radiation. And there are certainly drawbacks to those approaches. New insights have been developed recently that inflammatory or immune pathways are active in the tumor milieu, meaning in the area of the tumor. And what's amazing about that is that there are medications that have been developed for other kinds of tumors or cancer that target these pathways. And rather than trying to be comprehensive in the treatment of these tumors, I'm going to direct you to a talk from my colleague, Cassie Klein, from CHOP Neuro-Oncology. She actually gave a talk prior to this conference related to this. Sorry, one sec. Perfect. So what struck me when she taught me about the immune checkpoint inhibitors, which is a class of medications that they're considering using in these patients, is that I was actually already familiar with them because they have some known endocrine toxicities. So what's really interesting is they have immune activity and they go to the tissues of interest, but as a result, they can also lead to pathology. So autoimmunity is when the immune system attacks the body's own organs and interferes with their function. So in some individuals who are receiving these treatments, hypophysitis or autoimmune injury to the pituitary can also occur, as can other autoimmune endocrine conditions. Fortunately though, autoimmune hypophysitis from these conditions is very uncommon. So what I'm showing you here is a meta-analysis, a table showing the incidence of these problems across a number of studies in adults. And you'll see that the incidence is overall well less than 5%. It's interesting that endocrine complications may be more common in obese individuals, but fortunately overall remain quite rare. So on balance, we tolerate certainly a very low rate of endocrine complications to avoid the much higher rate of endocrine complications that can occur with surgery. So next I'm going to turn my attention to adrenal hormones, and I'm going to take you through a really terrific paper led by Dr. Arlt, who's a European endocrinologist. Her paper asks a really important question, which is, should we be doing stress dosing differently? So as this group well knows, critically ill individuals with adrenal insufficiency require stress dose hydrocortisone when they're sick. And the question she asked was, can we learn from studying the stress response in otherwise healthy individuals who are stressed to learn how to stress dose better in those with adrenal insufficiency? And this is such an important study. I'm going to take you through how she did it so you can understand how I think this may change our practice. So what she did was take two groups of healthy adults who were undergoing some kind of physiologic stress. So either healthy subjects before they were stressed, individuals experiencing combat stress in the military, major trauma like a car accident or sepsis, and she measured their cortisol levels. The next thing she did was take healthy individuals who are undergoing elective surgery, either shorter surgeries or more complicated surgeries, and measure their cortisol levels. And the thing she did after that was take individuals with primary adrenal insufficiency. So one note here, most folks with hypothalamic and pituitary tumors have secondary adrenal insufficiency, meaning the cortisol deficiency comes from the lack of signaling in the pituitary. Primary adrenal insufficiency means the adrenal gland itself is compromised and can't make cortisol. So these folks are slightly different, but I think we can still learn a lot from this study. So what she did was give these individuals the same total dose of hydrocortisone. So they're adults, they got 200 milligrams over 24 hours. But each individual on 4 different occasions got different dosing strategies. The first 3 were intermittent, every 6-hour dosing of oral, intramuscular, or intravenous. Or a fourth option was continuous intravenous administration, meaning a constant infusion of hydrocortisone. And then she measured cortisol levels. And I'll show you what they found. So first, they looked at minor operations, right? So very short, uncomplicated procedures. And what I'm showing you are cortisol levels in response to the oral, intramuscular, intermittent intravenous, or continuous intravenous formulations. And the blue line is the typical cortisol response in healthy individuals, and the light blue color shading shows the range of responses. And what we can take away from this graphic is that pretty much no matter what dosing strategy was used, safe cortisol levels were maintained. In other words, higher than what healthy individuals typically experience. So that reassures us that for short operations, we have flexibility with dosing strategies. Next, she looked at major operations. So the same approach was to look at the cortisol levels in response to the different drugs. But here the comparison is this red line, which is the median value, meaning the middle value of cortisol response, and the range of healthy individuals. And you'll notice compared to the last graphic, cortisol levels get much higher in response to major, longer operations, which makes sense given the stress on the body. The other thing she points out is that towards the end, towards this 5 to 6 hour time after the start of the operation, cortisol levels that are from the drug can go below typical in all of these except the continuous strategy. Now this study, I told you, was done in a different form of adrenal insufficiency and was done in adults. So we can't necessarily generalize to our pediatric patients. But the way this changes practice for me is that if we, for example, have a very sick individual in the intensive care unit who seems not to be responding well, one option I could bring up with our intensive care unit colleagues would be to try a continuous hydrocortisone infusion strategy to see if we can maintain cortisol levels in a safer range. The other thing that's relevant, of course, is that individuals with hypothalamic obesity may process cortisol differently, and so we may need to use different strategies or different studies to learn more. But this is a really important study for this year. The other interesting adrenal development that I noted from this year was the new availability of a hydrocortisone formulation. So as this group knows, liquid hydrocortisone has limited stability. So even for really little kids, we don't use liquid formulations of hydrocortisone, we use tablets. The trouble with that is that the available tablet strengths of hydrocortisone really don't offer us much dose flexibility for our smallest patients with pituitary problems, including neonates, infants, and smaller children. But as of this summer, hydrocortisone sprinkles have become available in strengths as low as 0.5 milligrams. So in comparison, the tablets are available in 5 milligram strength. And you can open these capsules and then sprinkle the sprinkles onto the tongue or onto food and dose that way, which gives us more dose flexibility, in particular at the smaller range, which really encourages me. And I'll just show you how the investigators showed that this formulation was equivalent to the kind that we usually use. So the way they do this is they take healthy adults, they give them dexamethasone, a steroid that suppresses their own endogenous function, and they give them hydrocortisone or the new sprinkle formulation and measure their cortisol responses. So you can see in this first graphic that whether they use the hydrocortisone, the tablet, the traditional form, or the sprinkles, the lines are on top of each other, which is reassuring. You can also see below here that the highest strength of sprinkles, the 10 milligrams, as we'd expect, produced higher cortisol levels than did the 5, the 2, or the 0.5. So I'm excited, looking forward to trying some of these formulations in our youngest patients. So switching gears now to growth hormone, another hormone many of our patients are taking. This study struck me because it treated a question that we get a lot, which is what is the safety of growth hormone over the course of the lifetime in individuals with non-malignant pituitary tumors? In other words, folks with non-malignant pituitary tumors like craniopharyngioma may be concerned that growth hormone could contribute to a risk for recurrence. That's been a theoretical issue that's been wondered about over a long time. The title of this paper is Growth Hormone Therapy Does Not Increase the Risk of Craniopharyngioma and Non-Functioning Pituitary Adenoma Recurrence. So the punchline is in the title, but I'll still take you through the study so you can learn from it as I did. So this was a single center adult series, including individuals with craniopharyngioma and non-functioning adenomas. Its design was a prospective study, meaning the investigators collected data as they went. They took individuals who'd had a standard diagnosis of adult growth hormone deficiency, and then asked their providers whether or not they were planning to start growth hormone. And that decision was made clinically. It was not a randomized trial. And then they followed these individuals via serial MRI. So one thing that struck me, this is the table that shows us the characteristics of all patients, those who did get growth hormone and those who did not. And I was first struck that many adults with growth hormone deficiency actually do not end up getting growth hormone. That's true in the US as well. In children who have growth hormone deficiency, the decision not to give growth hormone has more obvious consequences, meaning the children do not grow as well often. But here in adults, we think perhaps the clinicians were concerned about the aggressiveness of the tumor or the amount of residual tumor, and so made the decision not to treat. What they found in their analyses was traditional risk factors for recurrence, meaning the known risk factors, like having residual tumor is a risk factor for recurrence, still predicted recurrence, whereas the use of growth hormone did not. And I'll point out that similar conclusions have been drawn in pediatric studies. For example, one study, a European study of 79 individuals with hypothalamic-pituitary tumors, followed up over 16 years on average, and then a much larger registry, but followed up for a shorter time. So as these studies accumulate, they give us more and more confidence that the growth hormone replacement we choose to pursue is safe. Another exciting new formulation approval for this year is once weekly adult growth hormone. So as of just this fall, the growth hormone formulation for adults, instead of being given by daily subcutaneous injection, which many members of the audience will know well, there's now a form that can be given once a week. So this is a terrific advancement. I'm going to take you through this study so you can learn a little bit more about how this was approved. So this study was of 300 adults with growth hormone deficiency who had been off treatment or were newly starting treatment for at least 3 months. The investigators treated them for 34 weeks. And this is something I want to highlight to folks. The main outcome that they were interested in, that was the basis for their approval by the FDA, meaning the FDA felt like this was a meaningful outcome for patients, was the change in truncal fat. So in adults or individuals who are fully grown, we're not looking to make them grow taller with growth hormone, of course. We're looking to take advantage of metabolic benefits. And growth hormone is what we call lipolytic, meaning fat burning. And so one outcome of treatment is decreasing the amount of truncal fat, meaning fat around the middle. So we know individuals with growth hormone deficiency who aren't treated can accumulate fat kind of in the midsection, that ripply looking fat. And so the outcome that was evaluated in this study was the percent drop in that fat. And what the investigators did was compare use of the weekly formulation to the daily formulation to make sure they weren't different, and they weren't. So that's the basis of the approval. And we, of course, see this and wonder, when will this be available for pediatrics, right? Because this would be helpful to not have to give shots every day. So there has been at least one study, and more studies are ongoing, of this once weekly formulation. The one I'm going to share with you that was also published this year was 59 children who were prepubertal who had growth hormone deficiency. And a note for this group, individuals with intracranial tumors were not included. The rationale for this was that folks with intracranial tumors have other reasons not to grow well. So they were looking for the most simple and straightforward population to evaluate and isolate the effects of the once weekly medicine. And what they did, I'm going to introduce this to you so you're more familiar with some of how these trials work, was a dose finding study and then an extension. So the way they started was they put one group of individuals on usual daily growth hormone as a comparator, and then they tested 3 different doses of the weekly formulation. And then they looked to see how well children grew. And they chose the dose, and I'll show you the results in a moment that were the basis of that selection, and then move forward into a safety extension so they could continue following the patients for how well the medicine worked and also look for side effects. And they continued over that time the comparator of daily growth hormone, and then finally offered everyone the weekly injection. And I'll show you the main findings that they had. So the outcome in children for growth hormone studies, unlike in adults, of course, is annualized height velocity. meaning simply how many centimeters do these children grow each year. And so the findings are shown here from 26 weeks of therapy and then 52 weeks of therapy. And then this light blue is the height velocity in response to growth hormone given once a day. And then these yellow, green, and darker blue are height growth in response to increasing doses of the weekly formulation. And you can see the reason for which they chose this 0.16 mg per kg per week dose was that it most closely approximated and actually potentially even exceeded, although not significantly by statistics, the daily formulation. And also, fortunately, there were no excess rates of adverse outcomes, meaning side effects, that would limit the dosing choice. The other thing that I thought was really interesting about this study is that they used a new measure that they developed called the Child Impact Measure. And that was a way of trying to understand how overall well-being and health is affected by use of growth hormone, because there are lots of questions with respect to when to initiate growth hormone in our patients, and some observational data to suggest that beyond some of the metabolic benefits, there may be benefits for emotional and social health. So what this graphic shows is several different components of scores: emotional well-being, physical health, social well-being, and a total kind of summary score. And this bar shows a result that would favor the daily growth hormone versus a result that would favor the weekly hormone. And you can see at the lowest doses, these yellow, well, daily growth hormone performs better, which we might expect. But at the higher doses, there's a trend towards the weekly formulation, although it didn't achieve statistical significance. The reason I'm presenting this is I think that there's more to growth hormone than growth, and I think it behooves us to keep an eye on this dimension of treatment. Okay, so switching gears again, psychosocial function is a really important component of health and can be impaired in ways that I think we incompletely appreciate and understand in survivors of hypothalamic and pituitary brain tumors. But fortunately, lots of colleagues are working on this, and I want to share some of their work. So this study, which was out of Germany, Hermann Muller's group, looked at social cognition, and all of the papers that I'm going to share relate to social cognition, meaning not intellectual function, which is what we usually focus on, that for example, teaches kids to learn well and perform in school. That's very important, and that's rightly an important area of focus. But what actually sometimes gets less attention, but is really important for how kids feel, is how well they function socially. So we know that some of these brain tumor survivors may have differences in the way they function socially. So to study this, this group looked at 31 individuals who'd had craniopharyngioma. They ranged from age around 7 to young adulthood, and then they took a matched control group, 35 individuals who are age and sex matched, healthy controls. And they did some assessments that I'll show you on the next slides of emotional recognition and trustworthiness. And I'll tell you what they found. So this is really interesting to me. It's not my area of expertise, but I was really curious to learn more. So the top slide is one assay that they did showing us. They played auditory recordings of people who were conveying an emotion with their tone of expression. And then this is a validated set, right, where some people were conveying joy, pleasure, relief, or negative emotions like anxiety or anger or sadness. And then participants were asked to guess or infer the emotion that was being conveyed. And this on the y-axis here is the amount they got right. So these are the controls and these are the patients. And you can see there's a meaningful difference. The controls got more of these right than the patients did. And what was interesting, the patients, where they got it wrong was they didn't appreciate the negative expressions very well. And the investigators point out that this could really interfere with how folks function in the world. One other test they did was this assessment of trustworthiness, which I think was really interesting. So this test is people are shown faces, and this comes from a validated data set where lots and lots of people have been shown these faces and to say, you know, is this a trustworthy face or not? And you can see there might be a trend towards a difference between patients and controls, but it was not significant in their hands. The last test they did was an assessment of social cognition using a movie. And the way this test worked was to try to figure out the capacity of these patients to understand theory of mind. So this was a new area to me, but I learned about it for this talk, really interesting. So theory of mind really evaluates the individual's ability to attribute mental states to others, meaning being able to understand where another person is coming from by watching how they behave, and making that guess correctly really helps us function in the world. So it turns out that patients were more likely to get that intuition wrong, and the reason they were making mistakes was they weren't able to attribute mental states to others correctly. They just weren't having the capacity to make those inferences. So this has consequences that Matt Hawking, who has spoken to this group before, published on this year. And I'm struck by the simplicity of one of the assessments that they performed. So they asked one simple question, and then they did a lot of complex assessments to try to better understand their initial answer to that simple question. So the simple question was, can you name a friend? They asked this of children who had pediatric brain tumors, as well as children with non-central nervous system tumors. And the reason they did that was because they wondered whether or not the effect of having had a chronic illness as a child could also affect whether or not children reported having friends. So the children who had pediatric brain tumors, 61% of them could name a friend versus a higher proportion, 85%, of children with non-CNS tumors. And they found several risk factors for not being able to name a friend. One was children with CNS tumors who'd had a relapse. Another was an inability to recognize people's mood by looking at their faces. And another was attribution style, meaning what they inferred about how the person thought about them based on their behavior, whether or not they were thinking favorably or unfavorably. And so that kind of might affect how they approach a potential friend. Some of the sophisticated tests they did, I think, were really important because I think they point to ways that specific training strategies could be used to help kids develop the skills they need. Because one thing I also learned from this paper is that we should not think of these potential deficits as fixed, meaning these deficits some of them are amenable to training, much in the same way that deficits in reading or math might be amenable to training. So the way they did this next assessment that I thought was really interesting, they had kids look at standard movies, and the movies include kids who are playing together or kids who are playing in parallel, meaning both of them are playing but not together. And then they took typically developing children whose results are in blue, kids with autism spectrum disorder whose results are in red, and then pediatric brain tumor survivors whose results are in green. And they follow their eyes. They have special cameras that look at where their pupils are going. And it turns out that typically developing kids look most at faces when kids are playing either jointly or in parallel. And in contrast, you can see that kids with autism spectrum disorder or with pediatric brain tumors don't typically focus in on faces the way the typically developing kids do. And that finding, they suggested, could reflect that kids with either autism spectrum or pediatric brain tumors were not necessarily attending to the signals they would need to gather social information. So if you're not paying attention to someone's face, it's hard to know what their feelings are, and it's hard to navigate a social situation. But this could be an area where kids could be trained and hopefully improve. So that's psychosocial function. Switching gears now, it's 2020, and so we are going to talk about COVID-19. The European Endocrine Society, I think, has done a really great job generating a lot of helpful resources for patients and clinicians about how to help manage people who are affected with endocrine disorders and potentially at risk for COVID-19 or who are experiencing other problems related to the pandemic. So some of the guidance they give, individuals with hypopituitarism who become ill with any infection, we know, may have increased risk of complications. So the epidemic, we're still relatively early in trying to understand how it may affect different classes of individuals differently. But our previous experience suggests that we have to be thoughtful about appropriate care for viral illnesses in individuals with hypopituitarism. The other thing that they mentioned, which I think can't be overemphasized, is that understanding the patient experience is really crucial. And they have a terrific collection of patient quotations, and I've just curated two of them here that really resonated for me. One of them is from a pediatric patient with a tumor predisposition syndrome and who had recently transferred from pediatric to adult care. And that transition is already really complicated. It's going to be addressed at sessions tomorrow. And this individual pointed out that the lockdown made that transition even harder. This resonated with me really well in talking with some of our patients. This is a quotation from a parent of a child with multiple pituitary hormone deficiencies who said the complexity of Lewis's care needs make him vulnerable, as there are no family members or social care providers who could provide care if his parents became unwell. So it's certainly expected that family members would be concerned that Lewis or the child would become ill, but the stress that people experience worrying if they themselves as the carers are going to be sick is hard to underemphasize. So I'm glad also today there's some sessions are helping and supporting these incredibly hardworking caregivers who experience stress in this way. Collating practical recommendations to share with patients is helpful. I'm going to show you in the two remaining slides what those are. Taking advantage of telemedicine, that's been a silver lining of this pandemic for me, really being able to keep in touch with patients near and far this way. Brainstorming strategies to minimize risk is appropriate, but of course, not at the expense of essential care. Just one brief interval slide of one of the biggest pediatric collections of experience with COVID-19 so far that recapitulates our own experience that fortunately kids seem to experience overall less severe illness. They did find that in children as like in adults, obesity is associated with worse disease. So a few tips for those with adrenal insufficiency, they re-emphasize what I like here, the 3 E's. Education, ensuring that folks are familiar with sick day rules, masks and physical distancing, obviously very key. Ensuring sufficient supplies are available, including emergency injections, and also patient empowerment. So ensuring all of our patients have emergency letters that they could bring with them and are up to date on the local COVID-19 guidance. For severe illness, you saw the previous paper that suggested if someone's in the ICU that we could consider using continuous IV stress dose steroids, or even at more frequent intervals than we usually use might be helpful if someone's very ill. With respect to diabetes insipidus, they point out that a substantial proportion of individuals who are managed on DDAVP can intermittently become hyponatremic. So if labs are not being done, it may be helpful in folks with intact thirst to ensure they have at least one breakthrough a week, just to make sure that they're not accumulating excess fluid. But of course, ideally is making sure they get the labs that they need. DDAVP is available in subcutaneous, meaning in shots, or intranasal formulations. That's helpful to know if someone's vomiting and can't tolerate their oral dose. It's always good to have more options to help take care of those folks. Individuals who have diabetes insipidus who can get COVID may be at risk for different complications related to that disease. That's what our learning has suggested so far, and I think this just helps inform clinicians of how to be thoughtful about fluid administration and blood clot prevention if patients become very sick. And this literature, I should point out, is from the adult literature, because fortunately our pediatric patients who've been affected have done reasonably well so far. So with that, I'm going to reiterate my thanks, and I'm happy to take questions from the group.